This is the Health Physics Society. We're doing a think tank, a live stream, medical physics enterprise, quality and safety in the cloud. I'm honored to have a distinguished panel of 4 subject matter experts who I'll introduce individually, and we'll go through a series of discussions. Each member of the panel will have 15 minutes to talk about a specific question, and then the other members of the panel will have 2 minutes of discussion to add to the presentation, where the presenter then will have closing remarks for 2 minutes. I'll introduce the panel of experts. The first is Dr. Jordan, who's Program Director of Medical Physics Residency Program in Diagnostic Medicine and Nuclear Medicine at University Hospitals of Cleveland Medical Center. David is an expert in MRI imaging and safety, expert in quality control and optimization of medical imaging equipment. He's active member of numerous professional and scientific communities, including, and he's a committee member on the Association of AAPM Med Physics 3.0. Dave, in my opinion, is a definitive source for quality in diagnostic imaging, safety, communicating risk, and effective communication. Next is Chris Martell. Chris is a board-certified health physicist specializing in the estimation and quantification of human exposure to ionizing radiation for the past 11 years. Chris has been actively developing and refining methods for radiation dose tracking in the healthcare industry and in using the results to improving patient safety. Chris, I consider to be the father of dose tracking. And also, Chris literally wrote the book on medical health physics. If you go to Amazon.com and do a search for medical health physics, his book is the #1 hit. Next, we have the esteemed Dr. Trauber, and what I did with our next 2 panel subject matter experts, rather than read their bio, I did some scholarly research using Google, and I'm just going to read some of what I feel are the highlights of most distinction. Brian J. Trauber, MD, is radiation oncologist at Northeast Ohio VA Healthcare System. He's medical director of Quantitative Imaging Laboratory, Case Center for Imaging Research, School of Medicine. He's assistant professor, Department of Radiation Oncology, Case Western Reserve University School of Medicine. And I feel it's impressive if someone has, when you do the Google search, it's first 10 publications, and then when I scrolled all of Google scholarly publications, he has 84 publications. He's has 2 medical device startup ventures in healthcare communications and informatics, panel member of American Association of Physics and Medicine, AAPM, on robotic brachytherapy. He's on appropriateness criteria committee for treatment of bone metastasis with American College of Radiology, and co-founder, board member, Eloquence Communication, which I find very impressive. And then my Google scholarly research of Ray Music, he's tenured full professor at Case Western Reserve University. Teaches undergraduate and graduate courses in biomedical engineering, physics, and radiology residence. Chair, Faculty Senate Committee on Research, Chair, Faculty Senate Committee on Information and Communication Technology. He's the Radiation Safety Committee Chair, Radiation Drug Committee Chair, Distinguished Investigator, Academy of Radiology, Nuclear Medicine and Instrumentation Steering Committee, IEEE. He's a journal reviewer, grant reviewer, and he's also the principal investigator for Quantitative Imaging Laboratory. And what I found is a description of what they do. Leads a team of scientists, engineers, and physicians to develop and apply image-based methods for non-invasively quantifying blood flow, metabolism, transport, drug targets in order to measure differences in function between people that are healthy and which have disease, as well as measuring the improvement in function in order to guide therapy. I define that as modern medicine. And I consider the research that both Dr. Trauber and Dr. Music do is at the forefront of modern medicine. Principal investigator, what does that mean? It's key person on research grants from National Institute of Health, the National Science Foundation, Ohio State, private agencies, and companies with a total value of more than $35 million. Also of note, he has listed 17 patents, 224 publications, and we don't have enough time for me to read all 224 publications, so I just picked some phrases that I thought were cool from the topics. He does research on things like multimodality, reverse data reconstruction, deeply quenched enzyme sensors, accounting for cascade gammas in imaging, individual pixels or voxels, tissue-specific PET attenuation values, simplified methods for robust estimation of parameter values. I think we can all agree that they are truly subject matter experts in their field. So we will begin with Dr. Jordan, and your question is, Dr. Jordan, define medical physics enterprise.
Find it. There's a file. That's it. Okay, so maybe it has a slightly different turn of phrase. So I'm going to talk about what is enterprise medical physics, or a medical physics enterprise. So I don't have pictures of it in my slides. This is sort of a new idea. But I want to talk about what we mean when we say enterprise medical physics, some characteristics of what it means to provide medical physics services to an enterprise, in an enterprise, using an enterprise approach. Right? So what does all this mean? I'm not going to pull the dictionary definition card and say this is what enterprise means. We're just going to kind of come at this from a slightly different angle. Right? So enterprise medical physics inherently has to be scalable. Right? So healthcare is changing in its scale and its scope. It's relatively rare to have hospitals operating in isolation. Right? Hospitals are interacting with other hospitals, they're interacting with clinics. You have patients who are traveling between facilities. You have data that's crossing between facilities. You have shared systems. And I talked some yesterday about the economic factors, the consolidation of healthcare. So medical physics needs to keep pace with these larger changes in healthcare. And so we have to be able to reproduce what we do for an individual hospital in an individual hospital on a larger scale. We have to find ways to consistently deliver those services, deliver the value that they need for safety, for quality, for performance of the system. As the system grows, we have to be able to scale with it, right? So there's more complexity to this than adding staff, right? There's more complexity to this than doing more volume of the same work. We have to evolve the kinds of work that we're doing, the tools that we're using to do it in order to continue to deliver safety, quality, performance throughout these enterprises as they grow and as their complexity grows, okay? We have to think comprehensively about performance. So again, another point that I've spoken to some of you about during this program. So we always have to think about safety as our foundation, and we always have to expand from there with scientific principles, right? We're scientists at root. We use theory, we use experiment, we collect data, we do analysis, we apply the results. So as we're thinking about the picture of healthcare, we think about the experience of the patient, we think about the experience of the provider, right? We have to hold the line on safety. We have to make sure that that is assured as a foundation. We use our techniques, we use our knowledge about physics, we apply new technology, and we keep this broad perspective, right? As the enterprise grows, as the complexity grows, there are new opportunities that are going to emerge, there's new challenges that are going to emerge, so we have to keep an open perspective. Where are these new challenges and new opportunities going to come from so that we can be ready, right? Without this, we're going to lose the ability to scale and to continue to stay relevant to the healthcare enterprise. We've talked a lot about connectivity in this program, right? That's going to continue to be a theme. So as individual professionals, we need to remain connected to each other. In our organizations, we need to be connected to other parts of the organization, right? We work closely with clinical departments, we work closely with physicians, direct patient care staff, other support staff. More important than ever, that not only are we doing physics, but we're also doing information technology, right? We're aware of what's going on in education, we're aware of what's going on in research, regardless of the setting that we're in. So I work in an academic medical center. These are core parts of our mission. But as radiation safety professionals, a core part of our responsibilities is training, right? So in a sense, we're always teaching, and in a sense, it's one of the most important things we do, right? So we should be mindful about education, new methods, how do we connect with our learners, how do we teach them more effectively? This is going to continue to be an important part of this value proposition. In addition to that, we need to look at the connectivity of our devices and our data. Right? We're collecting more and more data all the time. We're using more and more different kinds of technology to do it. Our technologies are talking to each other. Our technologies are using other technologies to talk to other technologies. Okay? And if you think I'm kidding about this, the people in the room who work with me know that this is true. We use multiple computerized systems that send emails to each other. Okay? This is part of how we survive the scalability of the enterprise. Right? So we have to think about these connections, we have to think about where we can take advantage of these connections, and we have to be mindful of the risks that those connections bring. In the healthcare environment, I've said this before, we have a very high bar to fulfill when it comes to information security and the downstream goals that have to do with patient privacy, patient confidentiality. Right? So we have to be careful about setting a higher bar than what we see in the consumer technology marketplace. This is going to continue to be a theme. Our medical physics enterprise has got to be data-driven. Unfortunately, we have more data than ever before. So it's incumbent upon us in our lifelong learning to continue to study and understand data science, right? How do we deal with these large volumes of data? How do we make sense out of it? Some of you may be familiar with the term knowledge worker, and you may consider yourself a knowledge worker, you may not. There's a lot of different definitions for this. One definition that I like is that a knowledge worker is someone whose job is to add incremental value and add incremental meaning to information. That's a very good description for what we do. We receive information in one format, we apply judgment to it, we apply analysis to it, we pass on a different type of information, right? Summary, recommendations, judgments, etc. So we have to continue to get good at integrating larger and more diverse sources of data into our analysis and into our decision-making processes. And we have to learn how to harness the technology that's going to help us to do that at scale. Right, so technology forward means that we're looking to the future, we're looking to what's going to become available, we're thinking about how we're going to harness it, we're thinking about how we're going to neutralize the threats and the risks that it poses. Right, so we're going to hear in detail tonight about things like artificial intelligence and machine learning, and there's a ton of conversation about this going on. So we need to be thinking about all of the emerging technologies that are coming our way very, very quickly, right, exponential growth rates, and how are we going to adopt the ones that can help us, and how are we going to adapt to and deal with the ones that could potentially cause us trouble. Enterprise medical physics is going to need to be clinically integrated. Right? We're going to need to work very, very closely with physicians. We're going to need to work very, very closely with all the folks who provide direct patient care. And again, we have to understand what do they want and what do they need in the service of making their work faster, easier, better, more effective. And this includes understanding the patients themselves, right? Patients come in for healthcare, they'd like to leave with a better quality and quantity of life than they came. So it's incumbent upon us to understand how the work that we do day in and day out is going to impact those patients as they enter and leave the doors of the facility, right? Our job is not to manufacture spreadsheets and reports. Our job is to add incremental value and incremental meaning to information in a way that has an impact on the patient, in a way that has an impact on the folks who provide care to that patient. Right? And this goes hand in hand with being patient-focused. Right? So we heard in a presentation yesterday about health physicists spending time face-to-face talking with patients about radiological procedures. This is more important than it's ever been. The entire healthcare world is focused on patient-centric care. Right? More and more than ever, we're concerned not just with how well did we take care of that patient, but how does the patient feel about it? What was the patient's experience? Right? This is something that healthcare organizations are working hard to quantify. They're working hard to understand it. They're scoring themselves and benchmarking themselves because we don't want to make patients healthy at the expense of feeling like this was the worst experience they could possibly have. Right? We want patients to feel good and to feel good about how they got there. We want to be performance-oriented. We want to pay attention to what are we producing? What is our product? And this could be anything from patient outcomes to employee satisfaction and retention. So everything that we touch needs to be oriented to, again, we have a backstop of safety and compliance. We're not going to sacrifice that in the interest of new technology or the latest trend. But once we've satisfied those objectives, how are we going to harness technology and the latest trends in order to improve our performance to the highest possible level? And enterprise medical physics is based on systems thinking, right? So when we talk about connectivity, we talk about data science, and we talk about organizational behavior, things that study the way that systems behave and systems interact. And these can be systems of human individuals, human organizations. These can be systems of hardware, software, instrumentation, right? These are all things that are working together in this enterprise environment, right? So the scalability is increasing the number and the type and the diversity of systems that are interacting with each other. And those small ripple effects that can lead to downstream effects, that can lead to effects that are far removed. And so we are in a perfect position to understand how these systems behave, analyze these effects, and to be able to look for upstream and downstream signals that can affect performance. And we need to be mindful of operations. So it can be very easy to overlook the fact that changes that we would like to implement or recommendations that we make may not be compatible with the healthcare operations on the front lines. Right? So as we go forward and as our healthcare systems evolve and as our practice of medical physics, medical health physics evolve, we want to be very, very aware of exactly how our actions affect the folks on the front line, in the clinic, what's happening at the bedside. We want to understand those downstream effects, those systems interactions, whether it's policies, whether it's required procedures, whether it's changes in equipment, right? We want to understand how these things are going to have an impact on the way that the healthcare organization as a whole operates. We're going to need to embrace automation. We have more data coming in. We have more and larger facilities, larger volumes of patient procedures, larger patient populations to care for. Healthcare is evolving to say we have a focus on taking care of people who are sick, but we also have a focus on taking care of people who are well and keeping them well. This is a dramatic growth in the volume of patients and in the diversity of types of care we're providing. We are not experiencing the same growth in the number of professionals providing that care and supporting those individuals. Okay? The patient population and the diversity of procedures is going to grow much faster than our supply of medical physicists and medical health physicists. So we're going to need to take advantage of automation. And we're going to need to apply that framework of being thoughtful and careful about our technology. We're going to choose carefully the technologies that can help us manage those risks, but we will have to accept and embrace a degree of automation in order to handle the scale and the volume that we're going to be expected to support. So an enterprise medical physics organization needs to embrace continuous learning, right? So every project, every task should be feeding into an improvement effort for the future. What did we learn from this undertaking? What can we apply the next time? Everything that you do can become a template for the next time you see it. There are very going to be very few one-offs in the scale of what we're doing. So individually, we should be learning continuously. We should be attending formal events. We should be looking for opportunities in our day-to-day work to learn what we can from our colleagues around us, to learn what we can and internalize what I did today that can make my work faster, easier, better tomorrow. In addition, we need to be continuously teaching those we work with and those who would take the opportunity to learn from us. So this is an opportunity to help others in the healthcare organization who are not as aware of what we do to gain a better understanding. Well, I still don't know that much about radiation, but I do know that that radiation person taught me some very useful and interesting things. That's a really good start. And finally, we need to be mindful of our place in this broader healthcare ecosystem, right? So the nature of hospitals is changing, the nature of health systems is changing, the nature of patient populations is changing. The demographics of the patient populations are changing. So as those changes play out, all of those things are going to have an impact on what does the hospital want and need from us, what do the physicians want and need from us, what do the patients want and need from us. So we have to understand our place in all of that in order to continue to adapt and to be able to continue to grow and to provide the services that the healthcare enterprise is going to require. I think that's the end of my preamble.
Next, we'll allow the other members of the panel to
Say a few words.
say a
Should
few
I
words.
stand up there, Ron, or should I just do it right
No,
from
I
here?
think.
I'm going to sit down.
say-
Right from here, all right.
Peer review.
Peer review, if everyone can hear me. Point, counterpoint here. Yes, no, I agree completely with everything that Dave was talking about. And I'd like to focus on one part of what you were discussing from the enterprise medical physics approach was talked about data-driven. And I think that's where I live and trying to work with that data every single day. And I think we have a long ways to go. There's still a lot of work that we need to do in terms of having a common lexicon so that we can pass information that when someone says this is an apple, the person receiving it on the other side says, I understand what you're saying, this is an apple. And we don't have that yet today. So I think we have a lot of work to do in that area. So I think that in terms of being data-driven, it also comes down to the quality of that data. So if the quality of the data is not there, then we're not going to be able to get anything meaningful from that. And we haven't really defined a lot of what what do we mean by quality data? One of the things I'm concerned about is we want to be able to have all these different hospitals connecting and talking to one another. And that's one of the requirements that MACRA has been asking us to do. That's going to be really difficult when we don't share a common medical record number for a single patient, as other countries do, such as Sweden. We have a different healthcare delivery system, but over in other countries, you have one medical record number regardless of where you go. So you're able to follow and track that information. In the US, you can literally go across the street to another institution and you get a completely different number and a completely different medical record. And there's no reconciliation between the two. So from being able to manage the data at kind of an applied level, we have, I think, a long way to go, but that's certainly an opportunity for us as medical health physicists and others to be able to make a real contribution. So that's what I have, and I'd like to pass it on to our next speaker.
So I'm the poor worker bee physician. So in some ways I'm outmatched with my engineer and physics colleagues. But we have the same problem, I think, on a providing care level as far as like maintaining quality in a system. When I look at our system, we have 12 centers offering radiation, and you'd like to think you're getting the same quality no matter where you're going, but at the end of the day there's different levels of expertise. So when we're talking about automation and scalability, one of the things we're looking at is, are there decision support systems? Is there machine learning? Are there tasks that can be given to less qualified providers with the assistant of machine that it can bring the quality up? You're not going to take a world expert and necessarily make them better right away, but can you take a below average dosimetrist or a below average radiation oncologist and up their game by giving them decision support systems? So in some ways, I think we're trying to do something in parallel on the clinical side.
So Dave and I are colleagues in the same department, and also I have a role in the radiation safety program here. And so I understand part of his task is managing a large number of sites. So this idea of enterprise physics, I think, is not just hypothetical, something Dave lives day in and day out. So can you talk about sort of how that works for you and in the health system here?
So if we're talking about numbers, so we have our group manages radiation safety and diagnostic medical physics for 14 hospitals, one of which is a very large academic medical center. And then we have 50-some outpatient facilities that are part of the healthcare system that range from a single x-ray room in a physician office building to a full-service multimodality diagnostic imaging center. We have several mobile imaging trailers, PET CT, and a couple of MRIs. So these are out working across, I think now we're up to a 7-county service area, spanning across roughly a sixth of the state. So this is handled by a very small, very dedicated, very top-notch team that I'm privileged to work with. And so to keep everything in line and to keep track of, just simple things like what are the deadlines for annual testing for 40-some mammography systems or 40-some CT systems. We have to rely on systems that it seems very straightforward. Well, we put all the due dates in a spreadsheet. Well, except we have 8 different people that need to access that spreadsheet, and you can corrupt a spreadsheet file really fast. So just something as simple as a humble spreadsheet to find a solution where 8 different staff members can reliably access that information, refer to it, and update it is a problem we have to solve in order to be able to be out in our facilities doing our work instead of sitting in our office scratching our head and trying to figure out why the spreadsheet doesn't open today. And that's kind of the bottom of the pile of the things we have to manage. Where we see some benefits in this is across the system, we can apply a lot of uniformity with things like policy, where we can also do a lot of shared learning. So when we have an inspection at one facility and we find out there's a new point that our regulatory agencies are emphasizing that they're very concerned about, we can very quickly propagate that information to the entire network and say, okay, everybody with a CT scanner, let's go back and check this question that came up and we can potentially head off trouble throughout the rest of the network with that kind of information sharing. So it kind of cuts both ways. It presents some unique challenges, but I think it gives us some nice opportunities, and it gives us the scale to deploy things like dose tracking software or logging software for QC data and things of that nature. So I think we have some fortunate opportunities in that scale too.
Okay, Chris, your question is to describe cloud-based dose tracking and quality control.
All right, I'll start up in a moment, but yeah, we've been talking about a number of different issues here throughout the day, and information, collecting information. One of the things that we've been challenged with is we're collecting vast amounts of data, and that alone doesn't mean that we can use all of that data, that any of it even makes any sense. And that's something that we really need to strive to get a handle around, and try to develop something that will make a difference. As Dave said, we really want to be able to use information that will provide a better quality of life and quantity of life for our patients. This is intentionally unreadable, okay? Intentionally. This is a very small part of a very large file, but it's only one of many that we collect with a vast amount of data, and a lot of it is anonymized, so you'll see some weird figures in there. We collect a vast amount of data, and we have to be able to figure out and extract what actually is important. And that takes a lot of work. And one of the things I'd like to be able to do is be able to get the same type of information from all the types of equipment that's out there. And that's not going to happen anytime soon, probably not before I retire. We have a number of vendors having a variety of machines that are out there. We just still allow them to use private tags and things of that nature. So there's some things that are undecipherable to people trying to extract information from these files. So there's just a lot of data out there. It's data overload, complete data overload. And so now what we've got to try to do is extract something meaningful from all of this data. So that's one of the big challenges. And one of the way all of this kind of works is this. This is just kind of a snapshot. Hopefully this is a little more readable, but it basically shows some complexity, that there's a lot of different things. Dr. Jordan talked about all the different pieces of software that communicate one another, sending emails back and forth. And as a medical health physicist, this is something that, in order to be relevant to our jobs and our institutions, and to make sure we're prepared to meet the future, and the things that we have to do is manage data, we have to understand the terminology. So here you see a lot of different things. If you're not familiar with some of these things, then this is where you need to learn. ADT, admission, discharge, transfer information. Information about the demographics of patients when they come into a hospital. Then once they're in the hospital, things get ordered, things happen, and then all these messages, whether it's an ORU or an ORM message, start to get sent all around the institution. And tens of thousands of messages are constantly moving throughout the facility, talking to these multiple systems. And the way they do that is through HL7, the specific language that's used as a common language that everyone agrees they'll provide information according to, so that we can connect all these different things. It's a fairly old language, and maybe we'll see some changes to that coming in the future, but the cat's out of the bag at this point. All of these different systems now are relying on HL7 to make these connections and this communication to happen. We have ordering software and different types of information systems. PACS. PACS, the lifeblood of radiology. Other groups have their own PACS. Cardiology. Nuclear medicine doesn't have a PACS, depending on the hospital you're in. So even within a certain hospital, these different things may or may not exist in a variety of fashion. And typically a lot of groups, other than the VA, a lot of other private hospitals, the different groups are operated as their own profit and loss center. So they have to buy their own things. And that means if they don't have the money, they're not going to have the latest information or the latest technology to be able to allow a lot of this information to move from one location to another. We have all of the different devices, the X-ray generating devices that produce all kinds of files. That first slide I showed was actually from a fluoroscopic unit. Actually, I think it was from a DXR, a digital X-ray unit, to just collect information about a simple chest X-ray. When you start to get into things like fluoroscopy, you can have these files that just are extensive because there's a lot of events that occur during those procedures. So it's vast amounts of information, and it's really difficult to try to extract, as I said, extract that information. So it's definitely a challenge. And one of the things that you have to really guard against is bad data. There's a lot of data where a lot of the data that's in those files is based on information that's being typed in at the console by technologists and things of that sort. So you have typos, you have blank fields, you have fields that are just completely wrong. One obvious example is often you'll find that the date of birth for a patient and the age field that's in there and the time of the exam don't coincide. I've found from some of my own research for a pediatric facility, 10% of the data that was collected had an incorrect age of the patient. And when you're starting to collect data on age for pediatrics, that becomes critical. So if you're trying to show statistics and data that's based on age, you're going to come out with wrong conclusions. So the data, a lot of times the data is bad. So you have to find ways of understanding what data you have and is that data going to be usable. So I call it unclean data, and it really comes down to having excellent quality control and quality assurance of data. I always like to make sure that whenever I do any work at a location, I go in and I perform my own data quality review for all of the data. And it takes a long time to really understand what's happening. And I want to make sure that people can understand the limitations of your data. That's one of the most important things I feel a hospital needs to know. What are the limitations so you don't use data that shouldn't be used to make specific decisions? Because that's where you can affect quality of care for a patient. And the way I like to approach this, whenever I stole this from Stephen Covey, so that one of the things you really want to do, begin with the end in mind. It's a critical topic when you're dealing with data. You want to make sure you know what the data are that you're going to be using. And you want to know, what are we going to try to achieve with this data in terms of a quality program or dose monitoring or something? What do we want to do? What's the end goal? And once you define that, now you can work backwards and say, what data do we need to be collecting to achieve that goal? And what kind of quality of data do we need to make sure that it's correct? Correct data. If it's not correct, you end up crashing your satellite into Mars, right? So you have to understand what's happening. If everyone understood that reference to the metric versus the non-metric system, they got it wrong and their satellite crashed. You have to know what you've got, and you have to make sure it's good quality data. So that I don't think I took my full 15 minutes. And I did believe in Dr. Jordan's approach of minimalist approach to slides. So, and I wholeheartedly approved of that. So I'd be happy to pass off the next 2 minutes to each individual.
So I thought it was very interesting, and you were talking about, private tags, and I know we were just talking about Kiba, the other day. I know I was at a panel earlier in the year, and we were talking about, NIST has actually developed all these really great, vendor agnostic quantitative phantoms, and yet the community doesn't adopt them, and then also the vendors themselves don't really want to reveal their secret sauce. So where does your kind of this paradigm you're proposing fit in with the realities of, the commercial market?
The commercial market?
Yeah.
Yeah, that's, there are ways, and unfortunately, like even extracting things out of private tags, I try to figure them out and reverse engineer to figure out what those are. But then a lot of times, is it necessary to do that? So again, it's starting with beginning with the end in mind. What am I trying to collect? And do I have access to the data that I need to support that goal? Typically, that does happen. Okay. But yeah, they do hide the secret sauce, like fluoroscopy. Table height is critical to peak skin dose, and oftentimes that's hidden in there. And people have different reference points of how that's measured. And until we have some sort of consistency in how that performs, then it's always going to be a challenge. The other thing, we have DICOM conformance standards. Conformance standards. So it means that everyone's supposed to be following it, but they don't. I know there's one vendor out there that did not follow the DICOM conformance standard for dose. And so when you pull the data in, you end up having to massage it again because they didn't follow the standard. So it's a challenge. And everyone is different, or every vendor is different. The age of the software is different. And it's not as easy as we would like it to be. So, yeah.
So I'm assuming your formal educational training is in physics?
Yes.
But at the beginning, you talk a lot of computer gobbledygook terms. So my question is, how did you and when did you acquire that knowledge?
It's a good question. Yeah. Well, full disclosure, that I worked for Philips Healthcare. And as a physicist, I was actually the director of physics for Brigham and Women's in Boston. And I developed my own dose tracking software. And that was my first foray into trying to understand how all this information is being passed around. But I didn't really get into the really nitty-gritty details until I had to do dose tracking and troubleshoot at all these different hospitals why this machine won't connect to our software, and try to figure out, or more importantly, it's connected and it seems to be working, but the data I was asking for never got to my location. So I had to find out, follow the track through this quagmire of connections to figure out where the data was being filtered. So I had to learn it, I had to teach it to myself. And I had to talk to people, rely on my colleagues for information. And that's the big thing about what we're trying to do here. Build relationships and collaborate, because in order to get this information, you need to rely on other people. Not one person, even in the hospital, knows where all those connections are, and they don't know where all the data is being filtered and passed through. You have to talk to individual groups to get that information. I had to learn it on my own, and through all my mistakes and banging my head against the wall trying to figure out why I couldn't get the data that I wanted.
So I think it was really, really great of Chris as an industry guy to kind of take some of the blame on industry for some of the data quality and connectivity. Because I could sit here as a hospital guy and say, well, it's Philips' fault that our data quality is so difficult. But so I should do a fair part to reveal some of the hospital role in this. So as our freestanding hospitals evolve into sort of, from islands into these sort of continents of healthcare enterprise. And as our systems that used to be sort of freestanding systems are now sort of learning to talk to each other and learning to integrate, one of the problems we've created for ourselves in some cases is that our underlying, basis functions, our lookup tables, our reference data sets, were begun with a different end in mind than those ends which we now wish to pursue, but those standards are now rooted in place, and it's difficult or impossible in some cases to change them. Just a simple example from the world of dose tracking is the name and the code that tells you what type of an exam that you're doing. Certainly there are a number of hospitals that have an exam coding system in their electronic systems which arises from their billing processes, not from the exact clinical indication. So in a billing system, you don't really care what that CT of the abdomen and pelvis was done for. You just care that it's a CT of the abdomen and pelvis. So that makes it very hard if we're using a legacy exam coding scheme in the dose tracking world to differentiate and say, well, are we doing the correct thing for CTs of this particular body region that are done for different clinical indications? We've created a problem for ourselves in being able to sort that out. And the vendors who provide us with these tools are working very hard to give us patches and workarounds and fixer tools to kind of help untangle our own mess. But these schemas are very deeply rooted, and again, now that we've got all of these multiple systems that are talking to each other and they're all speaking this common language, we're trying to do 21st century e-commerce and software development, and we're speaking ancient languages from the times of Phoenician seagoing traders. So we just don't have words for some of the things we need to do, and that's a difficult problem because I think it's going to be unheard of to see a healthcare enterprise that's going to be able to overnight and simultaneously upgrade and modernize all of their information systems and all of the networks that connect them and all of the underlying sort of basis functions and lookup tables that drive those systems. We're going to have a long period of lock-in to these legacy issues we've created for ourselves.
Thank you. I'm sorry? Want to say anything else?
Any closing remarks, Chris, before we go on to Dr. Trauber?
No, I'd like to just pass it right on to him and see.
Very good.
Throw 'em right in.
Dr. Trauber, your question, please tell us about research and diagnostic imaging.
Okay. That's easy. Let's see, slideshow from the beginning. Okay. So, like I said, I feel a little outmatched, I gotta be honest. I feel like when I was in undergraduate school, I was obviously going into medicine, and I showed up for my differential equations class. And the professor started going over the syllabus, and they're like, oh, we're gonna use differential equations to predict weather patterns and chirping patterns of crickets. And I was like, what the heck? I'm in the wrong class. And I look around, and there's all these physicists, and they're like, yeah. I kind of feel like that up here with these three. But so I'm going to give a perspective on cancer imaging and cancer imaging research, really from a physician's perspective, but also from the perspective of a radiation oncologist. So someone who's using these images to make treatment decisions and actually incorporating them into my treatment plan. Just from some disclosures, I do have some funding. I don't think any of them are directly pertinent, but I never like to not disclose them. And one lesson I got, sage advice from an old advisor, was to do your acknowledgments first, because you always run out of time at the end because you talk too long. So Ron alluded to the Quantitative Imaging Lab, which is a group of researchers I co-lead with Dr. Music. And it's a really special group, and it's an interesting mix of people. It bridges 3 departments. It's researchers from biomedical engineering, radiology, and radiation oncology. So we have physicians from 2 specialties. We have biomedical engineers who specialize in image processing, machine learning, artificial intelligence, electrical engineering, robotics. We have cold chemists, radiochemists, therapeutic physicists. We work with Dave Jordan quite a bit on the diagnostic side. We have residents from radiology, radiation oncology, medical students, undergrads. And so both Ray and I are going to highlight some of the work we've been doing at Case Western. But certainly it's a team, and all these people with their different perspectives and different ideas contribute to all of that. It's certainly not a one pony show. So before I dive in, I wanted to spend just a couple minutes describing the modern radiation oncology workflow, because our specialty really has gone through a renaissance in the last 10 to 15 years, I think similar to radiology did in the 90s and early 2000s. So even 10 to 15 years ago, if you were to go see a radiation oncology, or if any of you have staffed a clinic, you would have seen a radiation oncologist doing a fluoroscopy, right? They would print out the films. They would take out a crayon, right, and draw their treatment port, okay? And you were done. You were done. That was your treatment, right? There wasn't really anything sophisticated about the treatment. That's how it started, and it was kind of a grandfathered specialty out of radiology. And then what happened over the last 10 to 15 years, we moved into 3D-based treatment planning. And so at the core of that is something we call the planning CT, which is the first part in the workflow here. And the major benefit of switching to CT was not so much for the radiation oncologist, but similar to a process of attenuation correction for PET, we actually get a density map, and we use that to model high energy photons, so 6 MV, 12 ME, 15 MV photons, and what that dose map's going to look like when we actually treat the patient. Well, as that process started, someone had the great idea, well, why don't we actually then start putting in a target volume instead of using crayons? And that may seem obvious, but actually what happened is they would get the planning CT to do the dose map. They would generate something called a digital reconstructive radiograph, a DRR. So the radiologist, the radiation oncologist would literally have them make a fluoroscopic film from the CT, and they would still draw with their crayon. Right? So you had the 3D imaging, but we wouldn't use it, okay? So then what happened is eventually, after you had a next generation of radiation oncologists, we are literally going through, and this is still happening today, slice by slice through a CT scan and contouring the target volume. So I'm going to use prostate cancer as an example throughout my talk today, but the same applies for breast cancer, cervical cancer, head and neck cancer. Slice by slice, I'm contouring in a prostate, okay? And then also we're looking at the organs at risk, or the tissues that are adjacent to the structures that we're treating. So I'm going slice by slice, contouring a rectum, slice by slice, contouring the bladder, penile bulb, neurovascular bundles. It's not a difficult task, but it's a very labor-intensive task, okay? And then what happened is, as we started getting more familiar with imaging, people were like, well, there's some anatomies where CT is not all that helpful. And prostate's a great example. When we look at prostate and prostate cancer, the prostate base abuts the bladder, the prostate apex abuts the penile bulb and some of the soft tissues, and so you can't really see the border. So someone had a brilliant idea, well, heck, why don't we use an imaging modality where you actually can see the prostate? Okay? This seems like, so obvious, but back in the day, this was like brilliant thoughts. And so we started with rigid registrations, and people did prospective studies, and what they found is that if you contoured a prostate on an MRI, your volume shrunk by 30 or 40%, right? So going slice by slice, your volume is smaller. That may not sound like a big deal. Well, it is a big deal. You can imagine if your rectum's sitting right behind, your bladder's on top, your penile bulb's below, and your volume's 30 to 40% bigger, the dose to your rectum, to your bladder, to your penile bulb, to your neurovascular bundle, all those structures are getting more radiation, your side effects go up, your complication rates go up, right? And then we got an era of deformable registration and PET, and so it got more and more complicated. But after those contours are done, it goes into a treatment planning console. They do multiple iterations of a radiation plan. We could spend a long time talking about 3D versus IMRT, intensely modulated radiation therapy, arc therapy, blah, blah, blah. It's outside the scope of the talk. But from the day we do a CT scan, fusion, contouring, and we come up with a plan that we're going to use to treat a patient, that process can take 10 to 14 days, multiple iterations of a plan. And then once we start today, we mostly do daily cone beam CTs to make sure the patient's in the right position. In the 2D area, we used to line them up to tattoos, right? But the external marks don't really align to what's going on with internal anatomy, so we take a daily image as we move forward. So there's been a renaissance in the last 10 to 15 years. In a lot of ways, radiation oncologists and therapeutic medical physicists are just kind of catching up to what's been going on in diagnostic radiology for the last 20 years. So when I was kind of thinking about what I wanted to talk about, and Ron kind of snowballed me as this kind of kept getting bigger and bigger, I thought I would use prostate cancer as an example, and I would talk about a current example of where we're using imaging in current practice, current good standard of care practice, and evidence of where we're using imaging like on a clinical trial, and where I think maybe things might be going in the next 10 to 15 years in the limited time he's given me. Okay. So I think a great example of a paradigm shifting imaging modality in the modern radiation oncology clinic is Axumin PET CT. Okay. So this is a new synthetic amino acid tracer that was just FDA approved in the last few years. And standard of care for men with a radical prostatectomy with a rising PSA. So if your prostate's out, your prostate cancer's out, your PSA should be 0. And then if their PSA starts climbing up, we know that the prostate cancer's back, right? And you would think that with all the sophisticated imaging we have that we could figure out what to treat. Well, standard of care for 20 years since the Phoenicians were sea trading, okay, we always just treated the prostate bed and everyone got the same dose, okay? And that was despite doing CTs of the abdomen and pelvis and getting bone scans. So when this thing came out, there was actually a clinical trial that was done, a very small trial, but it randomized to 2 arms. One got standard of care workup, bone scan, CT, abdomen and pelvis, and the other one got Axumin PET CT. 80% of the patients had positive findings. 40% of the findings in that clinical trial actually changed management for the patient. Think about that. An imaging study that changed management in 40% of the patients that got the study. That's huge. That's huge, right? So about 5% of the patients were upstaged from disease that was outside their pelvis. So that means I was about to treat someone that was going to get 8 weeks of radiation, all the side effects of radiation, the complications of radiation, after they already have the side effects and complications of a surgery, and I wouldn't have cured him anyway, right? That's a big deal. And then about 75% of patients were upstaged from just treating the prostate bed, which is standard of care, to actually also treating their draining lymphatics. So I would have put someone through 8 weeks of radiation, all the side effects and complications, but I would have missed where the cancer was. That's crazy, right? That's crazy. And there was another 25% of the patients where, based upon pathology, we would have targeted the lymph nodes, but we found the disease in the prostate bed. And so we were actually able to decrease the radiation field, decrease toxicity, and just focus on the area there was gross disease. So this modality has been a game changer and has really changed management for a lot of patients with biochemical failure following radical prostatectomy. So it changes field size, and it also changes radiation dose. And so if I think about, so that was one problem, what do we irradiate and what dose do we give? So if we look at also prostate cancer, what's a different problem? Okay, so if you look at cure rates for men with low risk and favorable risk prostate cancer, our cure rates are 90–95% at 10 years. Cure rates are great, right? Side effects are terrible. They're absolutely terrible, right? So a problem, and a way you could look at the problem is, well, we're not really going to improve that cure rate, but is there a way we can maintain the same cure rate but decrease the morbidity? Okay? So if you think about prostate cancer as opposed to, let's say, lung cancer, if someone has lung cancer, do we treat their entire lung? No, that's crazy, right? If someone has prostate cancer and part of their prostate, do we treat the whole prostate? Yeah, that's kind of crazy, right? So one of the things is now with MRI and the sensitivity and specificity of MRI being 70–80%, we've also got things like choline PET, we've got Axumin PET CT. One question in many of these favorable and intermediate risk prostate cancers is can we treat just a partial volume of the prostate? Okay, it's a reasonable thing. So actually we did a systematic analysis just recently. There's about 12 to 15 clinical trials that have been done with things like cryotherapy, HIFU, brachytherapy, and guess what? You can cure their prostate cancers, and they almost have no side effects. Crazy, right? This is all in small phase 1 clinical trials. Over at the Case Comprehensive Cancer Center, we actually have a current phase 1 clinical trial open where we're using a similar technology. We're doing MR-guided focal stereotactic body radiation therapy, right? So this is really appealing, and we'd like to open this trial eventually at the VA. But we're taking someone that would normally need 9 weeks of radiation to their whole prostate, and now we're just going to treat a portion of their prostate in 3 treatments. 9 weeks to 3 treatments, Monday, Wednesday, Friday, and then they're done. We've treated 3 patients on this clinical trial. We did the first one in the world in 2016. None of the patients have any acute side effects, and none of them have failed yet either. So if I think about this, and Dr. Jordan was talking about, the enterprise and how would this be scalable, right? Like, so at the end of the day, I can talk a big game. I'm in an ivory academic white tower, and I only do mushy, squishy stuff below my belly button. So how could we scale this to community practices, right? If you're in Mansfield or Medina. And I think this is an area, where, maybe artificial intelligence and machine learning could help, right? So if we look at the registration process, could we teach a machine to help a dosimetrist or a physicist do better deformable registration? Absolutely, right? Can we help a radiation oncologist in the community that doesn't have my level of expertise help with contouring? Absolutely. Can we help a dosimetrist who doesn't do as many plans doing machine-assisted radiation therapy planning? Absolutely. All these things are feasible. So I just use this as an example. This is just kind of demonstrating technical feasibility. This is a group of our clinicians that were collaborating with an image processing group here at Case Western Reserve University in the BME department. But basically, using some machine learning classifiers, we took T2 weighted MRIs and ADC maps, and were able to identify high-risk lesions. That was allowed to do auto-segmentation of a dominant nodule and the prostate, OARs, and that was used to generate a focal dose escalation treatment plan, right? This is totally doable. This is totally doable. And just the beginnings of this is starting to be seen commercially. Philips Healthcare actually has a device called UroNav, which helps with some auto-segmentation of dominant nodules for MR-guided biopsies. MIM software has some Atlas-based segmentation software that you can use to help delineate lymph node drainage in the pelvis, right, for providers who have less experience. So this is all totally doable. Ron's giving me the evil eye because I'm running out of time. So I'm gonna finish up here. And then just taking a step back and actually, thinking outside the box of not just, DICOM. If you think about pathology, that's still imaging, right? We're moving in an era of digital pathology. And what's the holy grail? Is identifying who we need to treat, because we actually overtreat a lot of people. There's some people that don't need salvage or adjuvant radiation therapy. So can we use extract textures from pathology to help us predict, in addition to the known clinical standards, right? So we know after a prostatectomy that Gleason score, original PSA, seminal vesicle involvement, blah, 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 right? All this stuff predicts for failure. But is there something inherent in the images that also is an independent predictor when combined with the clinical data can tell us who we need to treat? So this was a small, also, feasibility study where they trained it on about 70 data sets of people who had radical prostatectomies. They had 15 years of follow-up, so there's plenty of failures in there. And what they did is they extracted, using machine learning, they looked at the nuclear shape and cellular architecture, and they pulled out about 10 different features of there, and it found that that was an independent predictor, both in cancer tissues and the adjacent benign tissues, an independent predictor of the PSA coming back, in addition to the Gleason score. And when you combine that with the Gleason score and the PSA, it predicted almost 80% of which patients were going to have biochemical failure, right? So in theory, this could help us pick which patients are going to need treatment and which patients don't need treatment, and which ones then we can avoid the side effects and complications of radiation. So that's where I hope the field goes. Dr. Music will poo-poo it, and he's going to tell you about the hype of artificial intelligence and machine learning. So hopefully we'll have a lively discussion. Did I go over, Ron?
You are awesome. Dr. Music, how can you add to this discussion?
So Brian and I have been working together for quite a number of years now, and one thing I'd like to comment about is how valuable I feel the collaboration is working closely as a biomedical engineering, how valuable it's working with physicians understanding the clinical needs. I like developing technologies to solve problems, but I want to make sure those are relevant problems. And so, I think, so he and I are co-directors of the QIL. We work together in that regard. You want to make any comments on, you were poking fun at engineers, but you work with us every day.
Yeah, I feel bad for you all. No, it's great. So I'm actually married to a physicist, so I can get away with the jokes. But no, it's a great collaboration, and I think that's what's really special about our group is not only are there physicians involved, but there's physicians from multiple specialties. We have engineers, we have diagnostic physicists, therapeutic physicists, and all of us have our biases and different perspectives. And one of our graduate students and physicists in the audience, and we have heated lab meetings sometimes. That's good. It's good. I think it's good anyway. They probably disagree.
So I wanted to ask you about, so your interest in the value of imaging is clear, but I want to ask you about your interest in quantitative imaging. So, you talked about contouring, where we're still sort of looking at a picture of the tissue, but as we move forward, our ability to extract more measurements of the tissue rather than just pictures of it. Is there anything that's happening right now with quantitative imaging that is very promising in your field, and sort of where you feel really want to push it to the next level?
So your question is interesting, which is also why I was poking Chris a little bit. So the reality is that a lot of these machine learning and artificial intelligence techniques we're talking about are very sensitive to noise, right? So this concept of the secret sauce and even a radiologist sitting down at the scanner and mucking around with the pulse sequences, right? You start mucking around with things a little bit, all of a sudden your algorithm fails. And so if you develop something on a Siemens 3T, on their old version of software, and then you get an upgrade, or you try to translate it to a Philips system or a GE system, it doesn't necessarily translate. So that's why actually, things like Kiba and some of these NIST standards are of interest, particularly in the radiation oncology community. We were talking the other day, a lot of the Kiba members are actually radiation oncologists, right? Because in some ways, it actually impacts us even more. The radiologists are doing a phenomenal job, and I don't want to downplay that, but they're qualitatively interpreting the images, where we're doing something a little more quantitative, particularly if you're going to start looking at things like auto-segmentation. So it's a very valid point.
I'd like to ask a question too. Now that hopefully I'm not going to put you on the spot here.
Probably.
Great way to start off, right? Yeah. Something I've always wanted to ask a radiation oncologist, and now I get to ask you and put you on the spot, is this that you detailed some incredible science and some incredible medicine in terms of sophistication and everything else, and the use of new technologies. The thing that we've dealt with in the past, medical health physicists, is I like your opinion, and you don't have to answer if you don't want to, but why don't we treat thyroid cancer with the same level of sophistication?
So good question.
Metastatic thyroid cancer.
Yeah. So that is so you led me right into that. So that's so that's a hotly, I would say that is a hot controversial issue, right? So fundamentally, I assume you're talking about using radioactive iodine.
Right.
Right. So radiation oncologists, we do treat the anaplastic thyroid. So that's the stuff that's dedifferentiated, that doesn't take up iodine, and we do all these bells and whistles. So, and actually Ray and I are currently trying to develop a radiopharmaceutical that targets different cancers. And the reality is it's a different in philosophy. So for whatever reason, years ago, and I think it was largely monetary, unsealed sources, with the exception of brachytherapy, kind of went down a nuclear medicine route. And external beam and sealed sources for brachytherapy went down a radiation oncology route. And fundamentally, radiation oncologists and nuclear medicine physicians think very, very differently about therapeutic doses of radiation. Okay, so in general, I think nuclear medicine physicians think kind of like a medical oncologist, and you inject in what the patient can tolerate. Right, where we're looking at fractionation, normal tissue tolerances, can we give more than one dose? We look at biological modeling, your tumor control probability, normal tissue complication probability. And I think there are some centers in the US, for example, like WashU is a great example, where the Y90 liver embolization program is actually done by interventional radiology and by radiation oncology, and radiation oncology is the AU. And we do that, and they do that there because actually that treatment planning process, they actually do that for the Y90s. They're not just squirting in on a little dose and looking for shunt and then hoping it gets where they want to go. They're actually doing a three-dimensional treatment plan in a CT with contours after fusion with MR, right? And they're calculating the dose they need for tumor control probability, and they're calculating the normal tissue complication probability that the liver can tolerate. And what do you think happens when you do that? Your control rates go up and your toxicity goes down, right? But monetarily, there's always been a little bit of a political value. The reality is my specialty has never wanted it because it's not very lucrative. And nuclear medicine, I don't think, really has the training on 3D-based dose volume histograms and biological modeling. So, unfortunately, it's historic. It's historic. But your point's well taken.
Would it benefit from a more sophisticated approach?
Oh, it's already been proven.
Okay.
I mean, like I'm saying, it's pretty much. Okay. Yes, absolutely. I mean, you should probably do patient-specific dosimetry for any patient, regardless of whether it's Xofigo. I mean, Xofigo you can't really image, but So actually, a great example, and I'm going off topic, but you all familiar with like Bexar and Zevalin, right? These were amazing drugs, right? These were curing patients who had chemo-refractory non-Hodgkin's lymphoma. You know why it failed? Well, partly, but nuclear medicine physicians don't show up to tumor board, right? And then also, who controls that patient population? Like, who controls the referral pattern? Medical oncology, right? What do they give? Chemotherapy, right? So if a medical oncologist has a patient in front of them that's a candidate for Bexar or Zevalin, or they can give them another chemo, what do you think they're going to do? They're going to give more chemo, right? Because at the end of the day, whatever we want to say about it, this is a for-profit healthcare system, right? So Bexar and Zevalin were amazing drugs. There was actually an article written on this a couple years ago. It was an amazing drug, worked really, really well. It failed because of practice patterns. It's kind of sad, but it's the truth. It failed because of practice patterns. And I think, like for this drug, like Ray and I are developing, and the iodine thing, I think there's an opportunity for that, but we'd have to figure out a way, one, to make it, patient-specific therapy, quantitative imaging, patient-specific dosimetry and dosing. But you're going to have to figure out a way or a patient population that there's some kind of incentive for medical oncology, or it's a patient population that the referral pattern comes from surgery or from radiation oncology. Unfortunately, our start in Canada or Europe, where it's a different, or the VA, where people aren't, working for money. That's sad. I know it's sad. Delete that. Delete that. Delete that. I'm gonna get fired. All right.
Thank you, Dr. Trauber. Ray Music, your question is, please tell us about machine learning and artificial intelligence.
Well done, Joe.
All right, so artificial intelligence and machine learning are like the buzzwords these days. And so I want to tell you a little bit, before I go too much into some examples, I think I also want to tell you about what they are, because I suspect that there's many of us don't completely understand. And so one of my goals of this presentation is that you understand some of the mechanisms, the basics, the concepts. And so you can be a little bit critical too when you're reading the literature about what's possible, what might not be possible. So in machine learning and artificial intelligence methods, so it differs from a traditional computer analysis. So that requires a program where a person gives the rules to the computer. So if X, then Y, or you put in some mathematical formulas, and those are explicitly given by a human. So the machine learning approach is to let the computer directly learn from the data. So machine learning, it's a type of AI, artificial intelligence. And example of a simple machine learning method is to classify a group of items. So imagine you've collected some data points, and at every point you have two measurements. So we can plot those, say, on the x1 axis and the x2 axis, and you can come up with a distribution of points like shown there. You present those to the computer, and you ask the computer sort of try to group the data and find out how to divide it and classify or characterize it. And so the computer then basically tries to find a line or a rule to separate it without really any human interaction. So that would be one example, a clustering or a classification problem in machine learning. So AI certainly is hot in radiology. This is a quick snapshot from Ant Mini. So deep learning, artificial intelligence, diagnosing pneumonia better than radiologists, putting radiologists out of business. Later I'll show you an example. We're going to put Brian Trauber, radiation oncologist, out of business by drawing contours. Predicting dementia. So Brian would probably take the last one about me, predicting dementia. So AI is actually used outside of medicine, so I don't know to what extent you guys are aware of this. So AI is actually used in self-driving cars. It's used to play games. You guys probably know some of these, Go, chess, or like Jeopardy. Now the computers actually can beat expert humans. It's also used in language translation. So if you ever do like a Google Translate or something, sometimes it works better than others, I guess. So here's a couple of recent papers. This one came about machine learning. This is the first one I'll talk about briefly. It's machine learning for improved image reconstruction. It came out of Massachusetts General Hospital. I thought it was really fascinating. So basically they taught a computer to predict or to learn input-output patterns and to use that information to reconstruct MRI data. What I thought was particularly interesting about this is they trained it on natural photos, like photographs of natural scenes. So they took this large database of images and they encoded it as if it was collected using an MRI acquisition, like a helical spiral trajectory, non-Cartesian, or undersampled, something like that. And they created this sort of mimicking MRI raw data. And then they took that as the input to the algorithm, and then the desired output was the original photograph. And they presented a bunch of data sets like this computer and asked the computer to figure out how to come up with the target or the expected answer. And actually it worked pretty darn well. So most of the analyses they showed as examples are based on MRI. MRI is quite flexible. You can have all sorts of trajectories and encodings of the data. And I just grabbed two of the examples. And they show actually very good performance. So the auto map is what they call their method, and a conventional method. And you can look at errors of their auto map and the conventional error. And actually it does very favorably. And the algorithm in general can apply to other modalities. That's just one example. Here's one that I had to read a little more carefully, and I must admit I think I'm a skeptic about some aspects of this. So this is a study coming out of Stanford, and they said that with machine learning or AI processing of PET data, they can reduce the radiation dose by a factor of 200. So let me explain to you how they collected it. So again, it was sort of similar in that they collected high quality reference data. In this case, it was 10 millicuries injected into patients, 40 millicurie acquisition with the time of flight PET scanner. So that's going to be really high quality, really high statistics data. And this was from 9 patients with glioblastoma. So they take the list mode files, or basically the raw data from the PET, and they just randomly pick 0.5% of that data. And they say, okay, if we have this data, we want to generate this image, and the output or desired target image was the high quality image. And they trained the network to make that sort of a predicted image. And lo and behold, it worked pretty darn well. However, if you think about what they did, they start with really high statistics data. Probably nobody's going to inject 10 millicuries and go for 40 minutes of acquisition for a brain scan. You just normally wouldn't go anywhere near that long. So maybe 200 is a little bit over exaggerating the dose reduction that's possible. Also, here's one thing that I wonder about too, and it gets to the quality and the quantity of data. So their data was from glioblastoma patients. What if you had a PET scan from a patient who was normal? Would it take that scan and make it look like that person had glioblastoma? They really hadn't done the, I didn't see much about robustness in their testing. So, I think it's useful for us to understand these aspects of machine learning, AI, and how it works, so we can be critical evaluators of the claims. So some nuts and bolts of machine learning, how it works, what it can realistically do, I'd like to go over. So there's a few different types of tasks that it can be good at doing. One is called classification. You can look at image or looking at some data and determine, is it a normal or is there pathology present? And you can talk about those as labels. It's like one or the other. And certainly you can have multiple pathologies listed. You could do a regression type of analysis. This is where you could even have like a continuous variable. Can you predict a person's weight from their height? Another one is clustering analysis or clustering. So you can group objects. So objects that are similar should be identified with a common group or the same cluster, and objects that are different should be assigned to different clusters. And so in these general tasks, you could take two different approaches. One is unsupervised and one is supervised. So the unsupervised approach is basically you just throw the data at the computer and let it try to look for characteristics to distinguish the data, look at, identify patterns in the data. So it does not require classified or labeled data. In other words, you don't have to say, well, ahead of time, this patient has cancer, this one doesn't. You just let the computer algorithm look at it and try to figure out, group A is sort of similar, group B is similar, and maybe after the fact, the human would say, oh, group A is the patients with pathology. The supervised learning actually takes two steps to do. There's a training stage and a predicting stage. So in the training stage, you give it input. This is the data we want you to learn how to interpret, and here's some example right answers. So you give it data that could be labeled. So if you have a radiologist make an interpretation of the data, and you tell the computer, when you see this type of an image, this is the proper interpretation. Or you say, if you see this image, and this is where the boundary of the liver is, because Brian drew it, then you let the computer try to replicate Brian's drawing skills. So that's supervised learning. So you need an example data set where you have the answers provided. So there's a two-step. And one caveat or one caution with this is that the predictions can be unrealistic for situations not present in the training data. In fact, examples of this even come in the self-driving cars. You teach a car to drive under certain circumstances and something else happens. The car doesn't know how to react in a way that you want it to. So let me give you an example of an unsupervised learning. So there's an algorithm called k-means, and it's used for clustering or grouping of the data. So in this case, example I have animated here, think of we're trying to identify data or assign it to one of three groups. So K in this case is assigned by the human in advance 3. And so we want to then find sort of representative or sort of central tendencies of each group. And we can think of that as a centroid in this plane. So then you have the computer do a simple iteration. So first you take each data point and look at its distance to the other clusters, to the cluster centroids. And you find which one is closest to, and you say, okay, that data point belongs to this cluster. Then after you process and make the cluster assignments for each point, then you take all the points that are in one cluster and you calculate the centroids, so you update the centroids. And then you just keep repeating this process, and you stop when the cluster assignments do not change. So that's an example. We didn't provide it any information, what's normal, what's not normal, or what the labels or the answers are. Just Can you see patterns in the data? You ask the computer. Here's an example of a supervised learning. And so this, again, is one of the ones where we provided example correct answers. And so this method is called artificial neural network. And so it's actually used, or versions of it are used quite extensively. And it's modeled after or inspired by biological brains. So we have, see my pointer working? OK, good. So it's inspired, so we have neurons as the nodes, so that's represented here as the circles, and the connections sort of represent synapses. And so it's kind of very simple mathematics. The output from a node is calculated first by taking a weighted sum of the inputs. And then you take that result and you run it through what's called an activation function. That's shown in the lower curve here, lower plot. So activation function, you have creativity in how you pick that. It could be a threshold, a linear operation, sigmoid, whatever. You have many options, and each of those have parameters, as do the weights when you're making your weighted sum. So when you train the network, basically you're optimizing the weights of the summations and then the parameters of the activation function. So you go through the training phase, and then you lock down the weights, you lock down the thresholds, and then you use the network to do predictions. So usually the training takes quite a bit of computer time, and often actually the prediction is very fast because it's actually just basically a weighted sum sort of simple operation. And so sometimes you can do the prediction to analyze an image in small fractions of a second. So deep learning, you could think of it as an advanced form of artificial neural networks, or the ANN. And so you can think of like a hierarchy of the methods I'm talking about. So deep learning is the inside circle here, and it's a method that's of one of the artificial neural network approaches. Artificial neural network is one approach of machine learning, and machine learning is one approach of AI. So in deep learning, it's just sort of an extension of the artificial neural network. If you understood this, this is sort of simple. It just has additional layers of networks, additional layers of summing, additional weights, and just the computations just get heavier. And then the output layer here, these are like the last nodes. We can have values associated with this. So let's say one of my applications, I'm trying to figure out what a voxel is. Is a voxel fat or bone or whatever? So one of these outputs could consider like the probability of the voxel being bone. You can have like a 20% value of bone, or and another output could be probability of being soft tissue. So you can then make a prediction on a voxel by voxel basis, the composition, which can be used for a number of actually important medical applications. So Dave or somebody made a comment about quantification. So we may like to know the Hounsfield units, because from that we can calculate the radiation absorption probabilities and then do a radiation dose calculation. So a few caveats in all this machine learning stuff. So results can be unrealistic when you're doing a supervised learning method and you're trying to make a prediction based on data that's not seen in training. I think we also understand this as physicists. Extrapolating your data is sometimes dangerous. Another issue is that most, if not all, of the publications I see sort of use retrospective tests. It's not sometimes very robust evaluation. So if we do scans and come up with a way to process some at university hospitals with a certain brand of a scanner, a certain filtering, certain reconstruction parameters, certain technique in the patient, and then we take data from a scanner from a different manufacturer to a different site, et cetera, are the predictions going to be accurate? So I think a lot of times those aren't really evaluated very well. And another thing is that machine learning performance is also often black box oriented. So your self-driving car crashes, you can't identify which line of code caused the crash and how to fix that line of code. It's really a little bit of the challenge in, say, in these self-driving cars, with some of the majority of the technologies used in it. And the same applies in medical imaging. So computation, so deep learning, as you saw with all those layers of nodes and stuff, can be particularly intensive for the training period. And so one approach that actually has really helped things accelerate is GPU boards. So these fancy graphics these boards developed for these market driven by the hardcore gamers. We also could do scientific computations on them at a high level with relatively inexpensive good economics. Sometimes those computations don't really lend themselves well to GPU implementations, and you've got to use like a general purpose computer. So sometimes you just use a lot of computers in a cluster. We have a high performance computer group here at Case. And sometimes you just go into the cloud, Amazon Web Services or other places source computational resources. So in thinking about this and discussing with Dave prior to this, we talked about some potential safety and quality applications of AI and machine learning. So one could be quality control. So if you have an enterprise with, how many CT tubes do we have?
40-some.
40-some, over how many years? You can learn from patterns when the tube fails, perhaps. Maybe the algorithm can predict that in advance. And look, or when the calibrations start to drift. And can you take preemptive action? Or, with the, Chris was showing some DICOM tags from a header. Can you imagine having a PAC system with, I don't know how many millions of scans we go through here.
1 million every year.
Yeah. So that's a lot of data to analyze. So if you can learn from that when there are artifacts, and maybe when the artifacts are at an early point and quite subtle, and predict those and take corrective measures early. And so in this sort of analysis, the cloud approach is ideal because there's lots of data. Places like us have multiple sites, so you can access it externally, and also because of the computational performance in the cloud. And so I'd like to kind of wind down with a couple examples from our research with Brian and me, and actually as a point of, I guess, potential acknowledgement or disclosure. So we have an NIH grant that's an academic industry partnership, and our industrial partner is Philips. So we have a PET MRI system from Philips. One of the challenges of that are to correct for the PET data, the PET emission data for attenuation. So we don't have a CT scanner. That's normally what's used in a PET CT. So I love telling my MRI colleagues like this. We want to make your MRI images look just like a CT scan. But we also want to make them quantitative. We want quantitative Hounsfield units because we want to know what the attenuation is going to be. Another application, similar technology, another application is radiation treatment planning. Say they have these devices that are combining an MR and a LINAC, and you can image a patient while they're breathing, moving, even over longitudinally as the tumor shrinks. If we have a way to create an CT so you can do dose calcs, but yet you have the MR contrast to define contours, that would be ideal. So the processing in this works with the inputs, in our case, are MR images, and we use different pulse sequences, so we get different contrast information. One of our common machine learning methods is called fuzzy C-means. It's sort of an extended version of the K-means where we had the lines moving as we calculated cluster centroids. In this case, it's a generalization. We just calculate the probability of membership of each type, and then we can generate component CTs and synthetic CTs. So how do we do this? So we do a 3-echo MR acquisition, a UTE combining with a Dixon, and so we can calculate the R2 star, a Dixon FAT, and a Dixon water signal. And if we have a voxel that's air, basically all the signals are low. If we have one that's brain, you get like a low, low, high pattern, and so forth for these different tissue types. So we analyze the data, do clustering, and say, look, for all the voxels that have a characteristic like that, assign them to class 1, all the ones that have a sort of signature at the voxel level like this, class 2, and so forth. And then the human, after the fact, can look and say, oh, well, class 1, that's error. And so how we do this analysis, we can think of the data in 3 dimensions, but not in 3 spatial dimensions according to location, but in terms of the pixel value or the voxel value, the Dixon water, the Dixon FAT, and the R2 star. So we take those MR features, put them into this fuzzy C-means clustering, and we come out with these class images. And so the pixel value here represents, in our case, the probability of being error, and we have other classes too. So we can then make our synthetic CT as a weighted sum. So you take this image, multiply it by the Hounsfield value of error, this one, multiply it by the Hounsfield value of FAT, and so forth, and make a weighted sum, basically. And we can create then an image that looks pretty darn close to a measured CT, but we did it from MR data. We can also apply this method for whole body data in MR. We're sort of developing acquisition methods. That's some of the tricks in this. So Brian mentioned he likes hanging around with engineers. Well, his wife actually has a PhD in biomedical engineering. She probably could have taught that calculus or the DiffEQ class that you were in. But she was the brains behind defining these MR pulse sequences. And so we did the fuzzy C-means processing and came up with this component CT and synthetic CTs, just as I described for the brain. Another example, we hope maybe puts Brian out of business, I guess, is with his mind-numbing work. So just the automatic contouring. So we had some physicians draw boundaries of objects. And so these are organs at risk. We want to keep the radiation dose low. And they don't like, so usually it's funny, the oncologists don't like spending much time drawing those regions, but you show them a nicely drawn contour around a tumor and then they have to fiddle with that one. So anyway, so we basically, this is a supervised learning method. We take a lot of images where the contours were drawn by a human and basically try to teach a computer how to do this. So this is actually work that was presented at RSNA in 2017, and just in this week, we have word that it was approved, and actually this morning I received the proofs for that. And some of the other work, the example one, we also have a number of publications. So to kind of wind down, what is this about the AI and machine learning? So I think it has tremendous potential. It's still relatively immature, and I'd say we have to proceed with caution. I almost think, in this hype curve, you have a technology trigger. In our case, maybe it was some of the algorithms, and maybe it's the computational ability. But we get to people like overreacting and going a little crazy and maybe have unrealistic expectations. And wouldn't be too surprised if we're still relatively in this zone. We got to come back down to earth, be skeptical about what we're doing, and methodical, and do rigorous testing. And so, unlike Brian, I put the acknowledgement slide at the end. Again, opposite of Brian. So it's a big it's an endeavor. It's makes work fun because I learn stuff every day, having people with different areas of expertise than mine. It's also collaborative. We have people from WashU, Jinhan University in China. We had a visiting professor for a while. He's on some of our grants. We're on some of his. We have students and postdocs, etc. And that's pretty much it. One more funny slide here. And then open it up to the panelists, I guess, for questions.
That's me.
I answered all your questions. You don't have any questions.
So a lot of us here spend a lot of time dealing with regulations and with tightly regulated technologies. And I know you do as well in the work that we do together in the hospital. So you mentioned the black box nature of a lot of these machine learning technologies, and that you can't pinpoint a source of failure. And as we see medical devices, medical technologies that we may use in physics and radiation protection that rely on artificial intelligence, machine learning, some of these black box technologies. My sense right now is that the way that these things are being evaluated is sort of a very simple approach of it does what it says it does, or it works because it looks like it works all the times we've tried it. And I wondered if you had any ideas for one or two principles where we might be able to be a little bit more robust in our critical evaluation of whether a technology really works, that we could be thinking about without having to come up with a really sophisticated way to pull apart the black box and sort of find that line of code that doesn't exist. Are there any kind of guiding principles we should think about?
I think this is actually active area research. We don't really have any good solutions that have the rigor, the certainty of working all the time, every time. In that regard, actually, I sort of, joking about replacing some of the physicians. Actually, one of the things Brian talked about is a decision support tool. So at least for the immediate future, I think maybe that could be the role. Show it to the radiologist, show it to the radiation oncologist, show it to the therapist, the medical physicist. Let them make sure, sanity check it. scroll through the planes. It could save you a lot of time. Maybe you need to touch up some of the contours. But I really think, even in the cars, you can imagine how much money Google and these other companies invest in trying. Ford, all the auto companies, still they haven't solved that problem. And there is one company that's trying more like a rule-based approach. So it's maybe harder to develop the program initially, but maybe get to the finish line first with a product that they can trust.
Okay. Yeah, it was very interesting. I don't pretend to know half the things that you had up there. But as the industry guy, I guess I have to ask, how is this going to impact the cost of healthcare? And is the improvement going to be worth the dollars that would be spent? And is this really going to cost more?
I don't think, it's computers and computer time to do this and algorithms, and so the training may take a lot of computer time, and to the extent that networks can be trained and then once and then shared by a lot of people, actually the computation demands are pretty modest. To the extent that you can make, one company can make a scanner that could work faster because it does a reconstruction, which using a conventional approach would be too noisy to be acceptable. With a fancy machine learning reconstruction, maybe it actually has an acceptable noise level. So that's one way to improve a product. I think there's a lot of potential in these methods, but I think we have to proceed carefully. I think, as a vendor could develop the algorithms, develop the networks, and some of us in academia, maybe we would like a network that solves the problem for all images, all CT images from all vendors. Well, Philips maybe doesn't really care about that. They only want to, their problem is a little easier. They could characterize their scanner and develop a network, and in fact, maybe they don't want it to work well on data from another vendor. So I think there is room and role for vendors to get involved in this.
Thanks.
I abstain. It's too easy. I'll let the guests start asking questions.
What we've done is we've collected questions that were from online that have been streamed in, and my colleague Ramses Herrera will ask questions until we either run out of time or run out of energy.
Is this on? Hello? So we've got quite a few questions from online. Chris, you're popular. So we'll start with you. Let's see. This one came in from Daniel. Can dose-wise include machine learning system or neural networks to learn and identify patient body parts, regions based on scout images? I guess it's somebody familiar with the Philips products.
Yeah, it sounds like somebody who has one of our products. Yeah, that's something that I've actually I haven't delved into the actually using the word artificial intelligence yet, or machine learning. But yeah, that's something that I've been looking into and have a proof of concept actually for basically stealing a lot of the technology from radiation therapy and identifying, using our software to identify organ volumes and shapes and whatnot, and actually use that to calculate actual organ dose. For example, we'll just throw it out there. Philips owns Pinnacle, and it's one of the premier radiation therapy treatment planning software. And basically, it involves modeling the CT scanner as if it were a LINAC, and then using the actual software to calculate the volume and the dose being delivered to the organs. So that way, if the patient has an enlarged liver, you calculate the dose to the actual enlarged liver, or one kidney. You get results for one kidney. It's not it's not calculated based on a reference phantom. And so I have a proof of concept already on that, and it's quite a few organs as well. But I probably am looking at like 3 to 5 years before that would be commercially available. So that is something I'm working on.
Fantastic. This one's a general one. With the increasing automation of data collection within healthcare and advent of artificial intelligence and machine learning, do you see the potential for AI and machine learning to take over some of these monotonous activities performed by a medical physicist? Is it a good thing or a bad thing?
Is that for me, or who is that for?
That one's for general.
In general, I'll let Dr. Jordan take that one.
I gotta be really careful here. All right, so not exactly a neutrally worded question. So does medical physics potentially involve monotonous activities? It can. Should we embrace letting machine learning and artificial intelligence take over those activities? Yes, if they do them well, and if we're ready to do something equally or more valuable by the time those things are ready to take over. And certainly the latter is self-preservation, and the former is our responsibility to hold the line on safety and compliance and say, let's not take up some hot new toy just because it looks like fun. But no, I think that's very, very promising. Even just something as simple as moving routine data collection from paper-based forms or from individual files into an integrated database is very, very helpful because it speeds up review. You can automate the review and say, well, instead of having to go back and leaf through every page of the records, I just let the computer flag anything that's outside of the range I've defined. That by itself saves a tremendous amount of time and a tremendous amount of tedium. If you set up the rules of the game correctly and the data are relatively clean, to Chris's point, there's very little downside, and then you have time to stay in front of what's happening with new technology, what's happening, to develop your skills. How can you spend more time working more closely with clinicians and patients? I see it as a net good thing. I think it's important that we are the ones leading the charge. If someone else comes along and says, I have a computer that's going to mean you don't need a physicist anymore, I fear that day. So.
Well, physicists certainly provide a lot more value than just doing the monotonous activities, too. Involved in teaching, and there's a huge number of things that the physicist provides to the institution that can't be replaced, at least not yet, by a computer, So I do see that, that although we may move in that direction, I think it's going to be quite a long time. I think we see some incremental improvements, such as, having standardized phantoms with detectors actually built into them, where you can perform a scan and then take the data and actually send it to a physicist who could be located anywhere to actually analyze that data and make sure that it's correct. So he wouldn't have to be on site. So there's some incremental improvements we could do now and that are actually being looked at. So it's not something I just made up on the spot here. So it's definitely moving in that direction, but it's going to take a little time also for adoption. As Dave mentioned, people don't want to be out of work either. So you have to compete with that factor as well. But if there's a model for it, and I don't think it's going to replace medical physicists, it's just going to make them their job easier, so they'll actually have more time to spend on teaching and things of that nature. So.
Yeah, I think it could maybe be used as a tool to help scale things. So maybe take away some of the tedious tasks, but I think we'll still need human supervision.
One for Dr. Trahlberg. How are physicians adapting to on-demand, realistic DVHs, such as those found with the MR Linux system versus traditional TPS?
Oh my
and
goodness.
What is the role that you foresee for artificial intelligence?
Yeah, so that's a great question. So
That's my question.
Oh, what's your question?
I had to come from a therapy physicist.
So it was, so I glossed over a lot of stuff, but when we went through that radiation oncology workflow, and I talked about, we came up with a plan. You have to realize that was a snapshot in time, right? So if you're thinking about a prostate cancer, and then they're coming in every day for, let's say, 28 treatments. Every day they come in, their bladder might be slightly different level of filling. Their rectum might have a little more stool in it, a little more gas, a little less, and that prostate's moving on a daily basis. if there is stool in it, not only is it moving, but it actually causes deformation in the prostate, okay? However, when we plan it, that patient is giving the exact same plan every day. And there's actually been studies that have been published in the Red Journal and Medical Physics, and we're actually really, really good about using that cone beam and lining up to the prostate and hitting that prostate every day. The prostate every day gets, 250 centigrade or 180 centigrade. What changes is the dose that's being delivered daily to the bladder, to the rectum, and then depending on the stage of the cancer, we also treat the seminal vesicles and the lymph nodes. And so even though the seminal vesicles and lymph nodes are supposed to get the same dose, they might be getting, instead of 180, they might be getting 150 or 130 because they're moving independently from the prostate. So his question is alluding to is, what's the ability of what we call adaptive radiation therapy, so treating based upon the image that you see that day and adapting the plan. So I told you it takes 10 to 14 days to actually generate a plan. So how do we get to a point that we can do it on the fly in a matter of minutes? So right now I think there's two paths that people are going down. So some people are trying to look at cone beam and can you replan on the cone beam. What we've had is really there's only two vendors really. There's like Varian and Electa, and we had problems even collaborating with industry because it's not really DICOM. They're not held to DICOM standards. So actually even getting their raw data and reconstructing it and understanding what it is a challenge. And they don't do the same level of calibration. So the Hounsfield units you're getting, if you even want to call them that, are fluctuating and all over the place. So that's been challenging. And then on the MR, there's really two approaches. So what ViewRay did, which is the low field strength cobalt system, is they take a snapshot of the MR that day. They deform the planning CT to the MRI of the day, and then they transfer the electron density. They run like one iterative plan instead of starting from scratch. And so they can treat from image to treatment in about 45 minutes to an hour, which is pretty good. But in 45 minutes to an hour, you might have had a gas bubble come by or something like that, but it's a huge improvement. The other option and the approach we've taken is we want to generate a synthetic CT from that MR, so you don't have to worry about any errors in registration. And then I think we have to speed up the bottleneck. You have to speed up the planning process. And then the most labor-intensive part, and that was actually the collaboration that Ray showed there, was the physicians getting called to the ViewRay system and having to contour. So the automatic contouring is really just kind of an atlas-based segmentation or a gradient-based system right now, and it's not very robust. So literally the radiation oncologist is going down to the ViewRay system and contouring. So the two bottlenecks are the replanning and the contouring.
So we do parallel processing. We have multiple physicians draw the contours at once.
Yeah, so WashU was a little faster because the attending physician does the target volume, and they have the resident doing like the kidney and the liver and stuff in the background. But yeah, they've got it down to like 45 minutes to an hour.
It's what currently being done, just simple thresholding technique as far as the auto contouring?
Yeah, there's a thresholding technique. There's some things with like a gradient-based segmentation, but nothing like super sophisticated as of right now.
By the way, you mentioned one of the manufacturers of the MR, Linac. They have a Linac now too.
Yeah, the Electa product, yeah.
Well, and ViewRay also has a Linac.
Oh yeah, they have a Linac version as well.
Yeah, it's actually a local company. It's an Ohio company here, Cleveland. Next question. I guess it's best for Dr. Jordan. How do you see the role of the diagnostic physicist in radiation oncology, given that most of the development in RadOnc is in imaging? That came from Trajan or Trajan.
So I am a strong proponent of the view that most radiation oncology departments are reaching a transition point where they will need or want to add a physicist who has an imaging-centric background to their physics team fairly soon, because most radiation oncology departments now have more or less an entire radiology department's worth of advanced imaging capabilities right under their own roof, or they're trying to get them. So, we're seeing an increase. Certainly, there are very few radiation oncology departments that would be caught dead without a CT scanner. Many of them are working on setting up MRI scanners. We see PET CT scanners. We hear about SPECT CT. So, I think this is something that there's going to be a lot of opportunity for folks with a background in imaging to contribute to these departments. There's certainly more than enough work for our therapy physics colleagues to do without having to relearn and retrain all these technologies, although many of them are being asked to try. So, I think that's just a reality that, we as imaging physicists have to be ready for, and looking for opportunities to help and, not be surprised as we see that shift start to take place. And whether we think that that's a threat or an opportunity, I personally think it's an opportunity. Just waiting to see how that plays out.
Dr. Muzak, do you see facial recognition neural networks having a significant role in the future of healthcare, i.e. patient identification?
Yeah, I think it could, but I think, some of the old techniques also could, just how to identify a patient, just normal, simple questions. Sometimes don't use, unnecessarily complicated solution for a relatively simple problem, I guess. But some of the underlying technologies, so to analyze images and identify people, their facial features, and identify them, some of those same things could be used to interpret the images, or at least to provide the physician and some guidance in the content or composition and pathologies. Like I mentioned in that one example from Massachusetts General, they trained an MRI reconstruction based on natural scene photograph data. So some of the networks they trained to do facial recognition could certainly possibly have some of the applications to diagnosis.
Do you think perhaps in a very large healthcare network, let's say the VA, the largest in the country, that deals with a very particular patient cohort, it would have a value in identifying the patient, maybe when the state of mind is not correct, that a patient can come in, the face is red, and they know who the patient is, and their record comes up immediately. Do you see the role for that at all?
Yeah, and I could ask Dr. Trauber, I don't interact with patients on a daily basis. But and actually, I think some of that thing, so I do work with physicians quite frequently, and the facial recognition, the appearance of the patient, and what's their current status, how they feeling, that sort of stuff. It astounds me. So not being a physician, when I meet with a physician, pass them in the hall, getting coffee, they're like, "Are you okay? You look tired." And they pick up on these cues. So I suppose, maybe you could train networks, but use physicians as the gold standard truth to start with. But on the other hand, it kind of depends on who needs it. So engineers might need that kind of assistance.
Maybe Ricky needs it. Okay. How will quantum computing disrupt the healthcare industry and medical physics in particular?
Is that one for me?
From whomever wants to take it. Didn't specify.
Yeah. Actually, I don't really know that much about quantum computing. I know, some of it's used in encoding and encryption and decryption. You can, sort of provides a form of, I guess, parallel processing. I guess in some ways it wouldn't be surprising if you could use that sort of capability to do some machine learning methods. On the other hand, I think we're probably still quite a ways off to getting commercially available quantum computing.
Currently, there already exist systems, for example, RIT, that will do phantom analyses and data tracking in an enterprise-like way. However, I don't find this to be very useful. Do you have examples of systems currently in use that provide real value added? What are you doing today at your center?
Because that's to me.
I guess so.
So I alluded to this earlier. So we've migrated our data collection for our daily QC on CT scanners and our weekly QC on MRI scanners. We no longer have any notebooks, clipboards. It's all done in the cloud. And some of you guys who were with me earlier today were with me in an MRI suite, and you asked to see my QC records. I said, I can't show them to you because they're in the cloud and I don't have a computer right in front of me. And we have to hurry and get back downstairs, or I would pull them up. So, you know, this has been really eye-opening for me, because moving from an experience of visiting these machines once a year to do testing and then sitting and leafing through a year's worth of records, well, if it's March and I'm looking at an anomaly in the numbers from last August that nobody did anything about, it's kind of a little too late for me to deal with that, right? But if I can if I can set the computer a simple set of rules and say at the end of every month, tell me if there were any missing entries, right? And I can follow up on that, and that'll maybe keep me out of some trouble. And on a day-to-day basis, tell me if anything that's put in there doesn't fall within the range I've programmed. Well, now I find about it the same day or the next day. Now I can potentially do something about it. And the second piece that's, you know, we're starting to get into this now, and Ray alluded to this earlier, is we've built up these data sets over a course of several years for, you know, double-digit size fleets of scanners. And so looking back retrospectively, we can now try to associate trends in those numbers, even when we're within the passing ranges, and say, well, was there something changing, something drifting, something behaving unusually in those numbers that turned out to be a precursor to a significant equipment event? Right? Do we see trends in the data that ended up reflecting something major had we serviced with the equipment? X-ray tubes and detectors on the CT side, these are things that are disruptive for the clinic. They're disruptive for our workflow to go and deal with them. On the MRI side, you know, we can retrospectively see things with changes to the RF transmitters and the center frequencies, changes in the low contrast detectability and things like that. So we still have a lot of digging to do to make sense of what these things can mean, but we now have the ability to look at it where we would never have had the ability to go around and physically collect up all these notebooks and try to do that analysis from numbers that are written on paper record forms. It's simply not something we would be able to do. So, I mean, that's a very, very simplified example, and we're still relying on humans to interpret the images and come up with the numbers. It's just how we're collecting the data that's changed. So, more automation later, we may try it.
Perhaps Dr. Muzak can comment. Do you see perhaps being able to, artificial intelligence, statistical learning, machine learning, being able to analyze these results and gain more information than we can on a, you know, on a first look basis, being able to dig deeper and see beyond the obvious that a person could not, be able to trend things that we would not be able to think of?
Yeah, I think that it certainly is possible. I mean, as part of the capability, you could look at, like, you know, Dave said having all these notebooks is difficult to address, and so he puts them on you know, on the spreadsheets or other forms that can be shared. Well, having millions of images is even more difficult to deal with, and so maybe there's, you know, ways to automate the analysis of that and pick up trends that might be predictive of when attention is needed on equipment.
I wanted to refer back to something too related to that Chris mentioned earlier. So Chris was talking about clean data and some of the things that come about potentially as a result of human error in data entry. And that is something you have to watch out for. But I've also been counseled by some wise colleagues that in the world of big data, everybody's saying, well, we just want to throw tons and tons and tons of data at these systems and sort of extract meaning out of it. And certainly not all data are created equal in terms of quality. Data that are particularly valuable are data that are collected by individuals with a specific expertise, right? So data that, you know, you have a computer that's sitting and collecting weather reports day by day for a website, very, very different from data points that are generated by a radiation therapist or a technologist or a dosimetrist or a medical physicist who's putting a certain amount of training and expertise behind the collection of where do those numbers come from. So insofar as there is a potential for human error sometimes in data entry and data transcription, I'm sort of reluctant to throw the baby out with the bathwater, because I think that human involvement, you say, well, I have a CT technologist who's experienced, who's been shown the method for analyzing these images and coming up with these numbers. They also have a very, very intimate history of working with that equipment. They have almost an intuitive feel for when things are right and when things are not. And they're also very, very good at carrying out that procedure very, very reproducibly. So those numbers, I think, are very valuable given the human expertise that lies behind them.
So I could add a point to that. So when I described the two general classes, supervised learning and unsupervised learning, it's not actually, it's a little bit more complicated than that. So supervised learning, you have labels or the correct answers as reference. So for example, drawing contours on organs. So in those methods, it's assumed that the label data is correct, perfect. So that's often not the case. So Brian Trauber can only draw so many contours. All the other ones maybe are questionable. So there's some semi-supervised methods, technologies being developed. So it accounts for some imprecision in the quality of the data. So I just didn't have time to get into that. But yeah, so the machine learning methods are sort of looking into that, taking contingencies for that.
And our last two questions, I'm going to concatenate them. One from Satoru Nakamoto. Do you see an application of the blockchain to healthcare? Are you bullish on Bitcoin? And then, sure. And then, are you aware of applications of artificial intelligence or these sort of machine learning to verify or quantify the effects of alternative medicine?
I'll take the first one. I think Bitcoin sounds like fake money. I said that yesterday. I'll say it again. I think blockchain. I mean, I don't know anything about it except that it's it's what powers Bitcoin. But
They use GPUs too.
It uses GPUs, so it must be good. What little bit I know about blockchain makes me suspect that it might provide a way for institutions that are not directly connected to each other and have their systems plugged into each other to share information about things like patient records in a way that's more universal but still secure. I don't know if that's possible, but I've heard people talking about it, and it sounds like a good idea because, believe me, when you have patients who are moving between large health systems that don't plug into each other, and Chris mentioned the problem with the universal patient ID, maybe that is a possible application of a blockchain type technology. I don't know. It's certainly worth looking into. That could solve a lot of our interconnection problems across healthcare in a region or a nation.
Any takers on the second?
What was the second part of that?
If you're aware of any application of artificial intelligence to quantify or verify benefits of alternative medicines?
I don't see why it would have to be restricted to alternative medicines. I think the same validation techniques are relevant for any kind of medicine. I wouldn't exclude alternative medicine necessarily.
Are you aware of it being applied?
I'm not specifically aware of it being applied for that.
All right. Those are all the questions. Thank you. Pass the baton.
I thank the panel, and I'm truly amazed by the intellectual property that we have here. What I was hoping is that we could create what we have here as a unique opportunity, as an incubator, to think outside the box as healthcare is evolving. We need to evolve, and I just feel that it's amazing the amount of synergy that we have here, and I'm deeply indebted, and I'd like to express my gratitude to this fine panel of experts, and I feel they deserve a very warm